Good morning, everyone. My name is Rosita Ilieva, Director of Policy at the CUNY Urban Food Policy Institute. And on behalf of my colleagues, I would like to welcome everyone to our monthly Urban Food Policy Forum. Today's forum focuses on food is medicine, a topic that is of growing social and political salience and a domain where New York City's community-based practitioners, medical professionals, policymakers, funders, and academics have already an established record of leadership and commitment to deepening and expanding this important work. As we'll hear today, food is medicine is a multidimensional concept, stretching from the medicinal properties of certain foods and the harmful effects of others to the notion of food is deeply embedded in our culture in a form of care and being there for one another. But no matter the specific definition, as we'll hear today, a key question is how we can use food as a medicine as a tool for greater food equity and a strategy to reduce and eliminate health disparities. So before turning it over to our moderator, just a couple of quick announcements about our two upcoming forums in March. So on March 16th, and you see it here up on our screen, our next forum jointly organized with Hunter's College New York City Food Policy Center and the Tisch Food Center at Columbia University, we will host a forum on the topic New York Food 2025, policy recommendations for a stronger, healthier, and more just and sustainable food system in New York City. The forum is designed to educate and inspire stakeholders to support food policies and programs that will ensure New York City emerges from COVID-19 pandemic with a stronger, healthier, more just and sustainable food system. The registration link is already live on our website, so please check it out and consider joining us for that event as well. And on March 29th, our second forum for March, we'll host a forum on another key topic, institutional food and climate change, exploring the power of food procurement, public food procurement to advance environmental sustainability and social equity goals in tandem. So without further ado, please join me in welcoming our moderator, Margaret Horlick-Romanowski, Assistant Professor at the Department of Health and Nutrition Sciences at Brooklyn College, CUNY, and Faculty Fellow at the Institute. On to you, Margaret.
Thank you so much, Rosita. I really appreciate this, and I'm super excited about this forum and panel discussion. So I want to welcome everyone to today's panel discussion, and we're going to get started with the subject matter. The format is that the panelists will discuss multiple aspects of food is medicine, and we want our panelists to situate their topics in their specific work, and you'll hear what that is. And then around 11:40, we will turn to the Q&A to respond to questions from the audience. So feel free to post questions as we progress and the conversation progresses. And then also be sure to indicate whether your question is for a specific panelist. And then Rosita Ilieva will help curate the questions so that we can address as many as possible. So your question may be grouped with others so that we can, again, address as many concerns and ideas as we can in the short time that we have. So first, I'd like to have our panelists introduce themselves. They're going to tell you their name and current titles relevant to this talk. They all wear many hats. And then for further details, we invite our attendees to visit the event page to read our panelists' bios. And I think Rosita is going to post the link to the bios. So let's take it away, panelists. Tell us who you are.
Hi, sure. So I'll jump in first. My name is Katie Garfield. I'm a clinical instructor and the director of Whole Person Care at the Center for Health Law and Policy Innovation of Harvard Law School.
Good morning, everyone. I'm Diana Johnson. I'm a program officer with the Rockefeller Foundation's Food Initiative.
Good morning, everyone. I'm Michelle McMacken. I am Executive Director of Nutrition and Lifestyle Medicine for New York City Health and Hospitals.
Good morning, everyone. Thank you so much for having me, and thank you to all of you for being here. My name is Dr. Emma Steinberg. I am a pediatrician, a chef, and a pediatric culinary medicine consultant.
Morning, everyone. My name is Alyssa Wasung, and I am the Senior Director of Policy and Planning at God's Love We Deliver, the non-sectarian medically tailored meal provider in New York City. I'm also the Policy Committee Chair for the National Food is Medicine Coalition, which is a gathering of other medically tailored meal providers across the country, and I'm really thrilled to be here.
Thank you, everyone. So let's dive right into it. So Alyssa, you are alphabetically in the opposite order now. So we know that God's Love We Deliver originated during the AIDS crisis and was part of a massive grassroots response really to this urgent need to feed people who are critically ill with AIDS, but unserved. And I couldn't think of a better example of food as medicine as God's Love We Deliver, providing medically tailored home delivered meals, or MTMs as they've come to be known, to the critically ill. And I understand that you mentioned the Food is Medicine Coalition, and in partnership with God's Love We Deliver and the Center for Health Law and Policy Innovation at Harvard Law School, who we also have represented, are involved in this project called the Food is Medicine Accelerator, harnessing that massive funding available in the healthcare industry, which is very interesting. Where did we come from, and how expansive do you expect these medically tailored meal services to get?
Wonderful, Margaret. Thank you so much for that question. As many of my fellow panelists know, it's probably my favorite topic. So I think I'll start at the beginning. You know, the impact of the medically tailored meal model has really gained a lot of attention recently, but it's not new. As you noted, God's Love and many of our peer agencies started over 35 years ago at the height of the AIDS epidemic. You know, for God's Love, it was with our founder delivering a bag of groceries to a man who was dying of AIDS. She came back the next day and saw the groceries were still on the counter. And she realized that someone in that acute state of illness needed more than just food. They needed nutritious meals that were tailored to their illness, delivered to their home, so they could be as healthy as they could be for as long as possible. And she also realized that for that population, that meal was literally the difference between life and death. And that is how many of our agencies got started. Nutrition science was really a focus from the very beginning back then. We started our nutrition department staffed by registered dietitians, and they were really combating wasting in that population, helping people eat right for medications as they came on the scene, and transforming, you know, their health at that point. In 2001, we expanded our mission to serve people living with all critical illnesses in our community, really as a response to the need in our communities. So fast forward to today, God's Love is delivering 2.6 million medically tailored meals to about 10,000 people who are too sick to shop or cook for themselves in the New York City region. We really believe that illness affects an entire family. So we support our clients by feeding their caregivers and their children. And we do this with the tremendous help of our community and about 17,000 volunteers every year. So it's a tremendous community effort. Right now we're delivering in the New York City metropolitan area, including the surrounding counties, but we're also shipping and using telemedicine to expand our services. Most of our clients are living with multiple diagnoses. So about 42% are living with 4 or more illnesses at any time. And it makes it really impossible for them to take advantage of traditional emergency food supports. And for that population, which tends to be driving the cost of healthcare today, adding something as fundamental as a medically tailored meal can really transform their situation. And that's what the research is showing. You know, peer-reviewed research over the last 10 to 15 years of our partnership with healthcare is demonstrating the value proposition that when you add something like a medically tailored meal, you see a 50% reduction in hospitalization and 70% reduction in emergency room visits, and overall net healthcare savings that are really compelling, about 16%, and that includes the cost of the meal. So it's no surprise that healthcare is taking notice. But what is surprising is there's actually no dedicated federal funding for this service, save the Ryan White HIV/AIDS program. And that only covers people with HIV that are coming to us in need. And for God's Love, at least, it doesn't even cover all of those that come to us in need. most medically tailored meal agencies are raising the majority of their budgets across the country. For God's love, that's a whopping 65% of our budget every year. But there are some bright spots, as you noted. Healthcare is noticing and using waiver flexibilities and regulatory levers to expand access and really, solidify that partnership between healthcare and nutrition programs. And so we come to, that is really the genesis of our partnership with healthcare and the urgent need to expand these services. I posit that we will never reach our healthcare goals of improving outcomes and lowering costs, and most importantly, for mission-oriented organizations, creating equitable access to these services without fully integrating the medically tailored meal model into healthcare. And I think, as I finish this sort of genesis of our partnership and the view for the future and making sure people who need this service have access to it, I think that there is the broader question of, food is medicine in general, which involves many more structures than just healthcare. It's beyond clear that food is medicine. I think that's why we're all here today, from prevention to treatment. Healthy whole food to encourage prevention and health in our population, to tailored food boxes that prevent or halt the development of chronic illness, all the way to medically tailored meals, which I've just talked about. I think the bigger question really is who should provide and pay for the food, right? Our food system is in crisis, and it's pretty clear that healthcare can't fix that on its own. So I tend to approach these questions that we're talking about today, and I hope we get more into it from a gap filling perspective. Find the gaps in access for people and then work together to fill them. And right now there's no access for medically tailored meals, or at least piecemeal access for some, and that has to change. And then the last piece is, in thinking about food as medicine and the future of food as medicine relative to healthcare, how do we create the least access burdens for people who need these services? And I think we need to really look at integrating systems and connecting people to existing systems of food access, funding them adequately, and alleviating any of those bureaucratic burdens so we can focus on the services that people need. So I'm going to pause there and see if any of my fellow colleagues have any thoughts.
Well, I actually couldn't think of a better segue to the question to Michelle McMacken at Health and Hospitals. So we have, thank you so much, Alyssa. That was fabulous, and actually quite emotional, I want to say, to think of the history. So Michelle, in New York City, we have a long history of really extraordinary grassroots movements. God's Love We Deliver is one of them, but in terms of our food system and pushing back on the industrialization of our food provision services, and worked really hard. And that's really my history in New York City, was to enter this underground movement of the food systems work in the early 2000s. But everyone worked really hard to bring back healthier foods, scratch cooking, locally sourced foods, more sustainably sourced foods, and improving access to healthy food, and eliminating, as you said, Alyssa, a lot of the red tape, a lot of the bureaucracy, and also decreasing access to unhealthy foods, et cetera, et cetera, et cetera. The list is so long, but and eventually this movement has really pushed the issues to the mainstream, so that over the past 3 decades, New York City has been a trailblazer and on reduction of salt, removal of trans fats, et cetera. But also, and this has been collaborations between the Department of Health, the Board of Health, the Mayor's Office. We now have an Office of Food Policy, which we had for quite a while. And a slew of nonprofit organizations that you all intersect with, so that we're now reading the 10th edition of the New York City Food Metrics Report. I'm still blown away by that. So riding on this food movement, our new mayor, Eric Adams, is particularly focused and has a lot of momentum to ride on on increasing plant-based diets and healthier foods in our publicly funded meal programs. So can you talk about opportunities and challenges in the healthcare provision setting relative to vendors, meal preparers, clients, patients, and adopting and expanding this food as medicine approach in your system?
Sure. So first of all, thank you so much for having me, and thank you for that excellent question. There's so much to say. I will just start by talking about my experience at New York City Health and Hospitals, which most people probably know is really the largest public healthcare system in the United States. And I think in our system, we really have huge opportunities to apply this concept of food as medicine, and a really unique ability to sort of work to support vulnerable populations who may not have otherwise had access to a food as medicine approach. So within our system, I think that our food as medicine approach and our opportunities are really vast. So that extends from the actual food environment in our hospitals, so where our staff get their food, where what's available for folks to eat within the hospital system, the meals that we're serving our hospitalized patients, and one of my personal passions as a primary care physician for 18 years is really how do we expand this idea and this concept of food as medicine and nutrition in general across ambulatory care for chronic disease prevention and treatment. And I want to just start by acknowledging that one of the big challenges is the education of physicians and other healthcare providers. I mean, it's really, it's almost cliche at this point to say that, nutrition is not taught, extensively or sometimes even at all in medical school or in training, but unfortunately it's still true. It's starting to change in some schools, but it's still vastly under-taught relative to what we all here on this webinar know is really the incredibly critical role of food in health. So I will just say, when I personally, as a physician, sort of saw the light and started to study nutrition science, and I started to incorporate it in my own practice through dietary counseling, I saw that my patients, many of whom are facing huge barriers to being able to make changes, the vast majority really welcomed this conversation, and they wanted individualized advice. They wanted advice that was relevant to the foods that were part of their cultural traditions, the foods that their families like to eat, what was affordable to them, what was accessible to them. They really wanted to know. And I studied hard to try to meet that gap as an individual provider, but we know we're not, this is not a scalable solution. So what I started to do was really educate my colleagues. I developed a nutrition curriculum for the faculty in internal medicine, as well as for internal medicine residents and medical students, just around, helping people understand that food matters. It sounds so basic, but, just the basic concept that what we eat really makes a difference and is actually the leading cause of dying of a chronic disease in the United States. And then kind of sorting through the basic nutrition evidence so people are a little bit more immune to all of the messaging that's out there in the media and can really provide evidence-based advice to their patients. So really one of our key goals in my role at Health and Hospitals is going to be to educate physicians and other providers across the entire spectrum. So not just the physicians, nurse practitioners, physician assistants, nurses, PharmDs, medical techs, really provide these opportunities because it's incredibly rewarding when you actually reap the benefits and see patients be able to make healthier choices and support them. And I think, concurrent with that, we're going to want to increase the resources that are available to our patients for guidance on nutrition. So we're going to be increasing the written and video materials on nutrition for our patients, and really doing that with an eye to what's culturally relevant for patients, and really individualizing this for different communities, keeping, being sensitive to health literacy, digital literacy, and other things that really we know can stand in between of patients understanding the information that we're sharing. And I would argue, most importantly, increasing the number of dietitians in our system. It is crazy to think that patients don't have access to dietitian services. I could go on about insurance reimbursement. That's another, it's really unbelievable to me that many insurances will not pay for dietitian services unless you have type 2 diabetes or chronic kidney disease, when we know that so many of our patients can benefit, whether they have high blood pressure, high cholesterol, fatty liver. There's so many conditions that can benefit from nutrition services. So that's why, supporting the Medical Nutrition Therapy Act that's before Congress to expand those reimbursable conditions would be great. And I'd also like to foster better partnerships between dietitians and physicians and other healthcare providers, so it's really integrated as a team. The big picture here is to weave nutrition into the fabric of care that we're offering at health and hospitals, especially in primary care. And I would also just say that all of this really requires that we concurrently focus on social needs of our patients. So it's one thing to tell patient, to guide a patient around, these are some of the healthier foods that you can choose. But if a patient has food insecurity or they don't have access, obviously that advice is not going to be, it's not appropriate to just focus on that. So we're really working to explore ways that we can encourage and really make screening for food insecurity a routine part of all visits. Make sure that we have the capacity also to address food insecurity, so increasing our linkages to food navigators. We're using community health workers more and more, and we are incorporating those into our primary care models so that we can really address this more. And of course, our core social work team, who can enroll patients in SNAP benefits if they qualify, and link to other nutrition incentive programs. So that's sort of the landscape around the nutrition education environment. And then I want to take a few minutes to talk about something that's been a huge passion for me, which is the development of dedicated lifestyle medicine programs. And this is a program that I helped launch at Bellevue Hospital in 2019 called the Plant-Based Lifestyle Medicine Program. And this was really born out of the advocacy of Eric Adams as borough president, with the idea being that we were going to offer dedicated support to the highest risk communities who are living with cardiometabolic disease. So pre-diabetes, hypertension, high cholesterol, type 2 diabetes, heart disease, or health concerns related to obesity. We were going to use a core team of a physician linked closely with a dietitian and a health coach to support our patients across all the pillars of lifestyle change. With a big emphasis on nutrition, but of course we all know that if you're not sleeping well, you're probably not going to make the same food choices as if you were rested. If you are not exercising, you're missing a big component of your lifestyle change. Reducing stress, avoiding unhealthy substances like tobacco, and really helping people feel more socially connected and fostering those connections. We emphasized for the nutrition component a plant-based approach, so I'll just touch briefly on what that entails. Really, our goal is to help patients celebrate on their plate the healthy plant foods such as fruits and vegetables, whole grains, legumes, nuts and seeds, and really start to have those foods take a bigger portion of the plate, and sort of, not so much about emphasizing what patients are going to avoid, but celebrating the positive, what we're trying to add to the plate. And we know that sort of this plant-based approach has tremendous evidence behind it for chronic disease risk reduction and even treatment. And it's aligned with all of the nutrition guidelines, such as the American College of Cardiology, the American Association of Clinical Endocrinology, American Heart Association, cancer risk reduction guidelines. So that was really our philosophy. And in our Bellevue program, we saw huge demand across the community. When we first launched, we ended up with a waiting list of almost 900 people from the broader New York City area wanting to join this type of a program. So I think there's huge demand from our communities in wanting to use a lifestyle and food as medicine approach. And the healthcare systems have to just catch up with that, which fortunately they're starting to do. And last, I'll just mention that now I have the privilege with the support of the mayor and our hospital system, of being able to expand our Bellevue program model to 6 new sites in our health and hospital system, and that includes all 5 boroughs. So our goal is really to reach, again, our highest risk patients, those who are the communities that are facing the highest burden of chronic disease, who really need that individualized support and guidance, who also need the social support for addressing social needs, and putting that all in a package together, really to help people reach their optimal, the optimal lifestyle that they can reach. So I will stop there. I could go on and on, but I really appreciate everyone's interest in this space.
Thank you so much, Michelle. I really appreciate that. We are currently working on a new grant for a diabetes prevention program that will be tailored to the Black Caribbean communities in Brooklyn. And so I'm with you. We'll be talking. So, it has come up so far a lot about like who's paying and who's also controlling these efforts. So I'd like to turn to Diana Johnson. So in public health, which is my field, we've seen a continuous stream of medicalization of practices and services that really reside outside of medicine, but be absorbed by the field of medicine and the pharmaceutical industry. Historically, we're looking at midwifery, vaccinations, functional foods, and now food or meal prescriptions, right? This idea that food is now also in the medical realm. And we can think of it, I think, a little bit as some form of appropriation or controlling something that really, in my view, resides maybe somewhere else. So, but at the same time, we have a lot of power. So it's my understanding that the Rockefeller Foundation is investing in the advancement of food as medicine interventions that both help prevent, manage, and treat illnesses. So not just the medicalization, but actually trying to prevent that people will need medical care. And but part of it is in this approach is that doctors could prescribe produce or healthy meals as easily as pharmaceuticals and reduce the need for hopefully expensive and invasive health services. So I'd like to return to the question of equity that has come up as an undercurrent and ask you to speak to who benefits, who pays, and who profits from food as medicine initiatives.
Thanks, Margaret, for that question, and thanks to the CUNY Urban Food Policy Institute for inviting me. I'm always happy to join these panels as a former employee of the CUNY Institute. So great to see you all today. You know, to answer your question, Margaret, which is kind of multi-layered, the Rockefeller Foundation, really our goal is through the food as medicine work has been to engage healthcare payers and policymakers to redirect money in the system to support the scaling of nutrition incentives and healthcare delivery. And to that end, healthcare payers in particular need a strong business case to do that. And so part of what we've been doing is to support that shift is to help fund groups that are building the evidence that these programs work. Bringing food into healthcare is a promising way to improve health outcomes and potentially reduce the cost. We're supporting policy and regulatory change in order to do that at the federal and state level. We're also supporting the infrastructure for food as medicine programs to scale, and all with the policy goal of influencing Medicare and Medicaid to cover the cost of food prescriptions for its beneficiaries. That's our 10-year goal. And in terms of who that would impact and benefit, you know, that's the potential to impact 30 million low-income Americans who currently use Medicare and Medicaid. And I will say, you know, I just want to acknowledge that there's a gap. You know, not everyone has equal access to healthcare. So this is just one particular solution that is integrating healthcare with the food system. But I just want to, you know, ground it in the fact that we understand that not everyone is currently accessing healthcare equally. And in terms of who it benefits, you know, there are lots of groups involved in the ecosystem of both delivering and receiving nutrition incentives in the healthcare system. There are participants of the programs, of course, that would receive or improve their health outcomes by increasing consumption of fruits and vegetables. And we're seeing some really good research come out from GUSNIP, which is the USDA federal funding for grantees who are delivering these programs. They've seen that in some recent research. We also see that there's the potential for local food access organizations to support their communities by delivering these programs. And they sit in a very unique place of understanding their communities and the needs of that community. In some cases, things like produce prescription programs can even benefit the local economy as well if the food is coming from local producers and it's sourced equitably. And then, of course, healthcare payers, from their perspective, this participation in programs like this can indicate higher or can show better member satisfaction from the beneficiaries who are using the programs. And there is some potential to reduce healthcare costs. So there's lots of potential benefits across the sector and different audiences that are receiving these programs. But to your question about medicalization, I think there is the medicalization, but there's also the potential commercialization of these programs. And I think that's a major factor to kind of track as food as medicine programs are scaling. Food as medicine programs often have come from community innovations, from community-based organizations really understanding what the community is looking for in terms of food. But there is a growing interest in the industry, both in the private sector, looking at retailers and other food delivery commercial programs that are looking at scaling food as medicine programs. So that's a major consideration to think about as we scale these programs and make policy changes to integrate it into healthcare delivery.
Well, thank you, Diana. Really appreciate it. Yes, so that multiple players and multiple layers, but also this how do we control the situation so that we actually address the issues of equity. And I want to refer back to what Alyssa mentioned in the beginning of the broken food system that is producing these outcomes that we are now attempting to repair and push back on and try to prevent in future generations. So thank you so much, Diana, for that piece. I'd like to turn now to, unless other comments, you can always let me know. I'd like to turn to Katie Garfield at the Center for Health Law and Policy Innovation of Harvard Law School. Academia has we like a lot of long names. So you are part of one of your responsibilities is the whole person care initiatives, which I really like the sound of that, which includes the Center's Food is Medicine project. And I'm wondering if you can speak a bit about your work with community-based organizations. This is again a perfect segue. I have to thank the panelists for really leading to the next person. This idea that community-based organizations, state agencies, and healthcare providers and coalitions that you have assembled these together to develop strategies to increase access to these innovative services such as food as medicine. What do you think are the most promising food as medicine policies and initiatives out there that focus on increasing access to these services?
Absolutely. Thank you for that question. As you mentioned, we have the incredible honor to work with organizations and coalitions across the country on this issue. Particularly when we're working with coalitions, we're often working to advance promising policies, and then often with individual organizations to think about what does their policy environment look like in their state or their town and their local area to understand what opportunities they could tap into. And I think as we talk about what are the most promising opportunities, it's important to sort of step back and think about sort of the broader policy landscape that we're operating in and sort of what limitations it's also putting on this space as we think about where we have to advance to make progress. And I'll drop a little infographic in the chat that I think is sort of helpful. And I know some of you on this call have probably heard me make this analogy before, but I think it's really helpful to sort of explain the state of our healthcare system. And so that analogy is really to think a little bit of our healthcare system as kind of a house, right? You have your front door, and that's where all of our really traditional healthcare services are coming in. You know, your physician services, your hospital stays, your prescription medications. Those are covered as part of baseline benefits in Medicaid and Medicare and commercial insurance. It's accepted. It's hopefully reaching the right people through those avenues in an equitable way. I would say food is medicine programs, food is medicine services right now are not, I think we have to start as a baseline, are not coming in through the front door, right? And Alyssa alluded to this a little bit in thinking about what are sort of the opportunities. Instead, if you think of this house analogy, I would say food is medicine services, like many services responding to the social determinants of health, are instead sort of getting in through the windows. There are these windows of opportunities, if you will, in programs like Medicaid, Medicare, and even in commercial insurance, where we are seeing some flexibilities that are allowing some payment for these services, but they are sort of limited. They're often at the choice of individual plans or individual states. And so they're reaching some people in our healthcare system, but not all. And oftentimes that's going to depend on your geography, your individual plan, and sort of which healthcare program you're in. So I just want to start by saying the opportunities that I'm raising up today, I think are very valuable and are incredibly important to creating momentum in this space and sort of building towards the broader goal of equitable access. But I will say they're not the be all end all because of that sort of patchwork approach that's leaving many people across the country without access at this moment. So I'll sort of start with what are the key opportunities that I see in those flexibilities, because again, I think they're very positive and they're ways to improve access and importantly to sustain and scale up some of the existing programs so that they can also reach a greater sort of geography. And I think some of the key opportunities we're seeing right now are particularly in the Medicaid and Medicare programs. In Medicaid, we're seeing some great advancements, particularly through flexibilities like Medicaid waivers and some of the flexibilities that are built into managed care. So to give you some concrete examples, if we think about waivers, there's some really great work that's happening right now in states like Massachusetts, Oregon, and North Carolina to use waivers to really explore ways to fund these services and to evaluate their impact. One of the things, I'll be biased because I'm from Massachusetts, so I'll highlight them in particular. One of the things I'm really excited to see there is in their previous 1115 waiver, they had created a program called Flexible Services that allows our newly created accountable care organizations to pay for services that are providing nutrition and housing supports to certain Medicaid enrollees. That was a really big step forward. It's been a really important source of funding and support for food as medicine programs in our state, especially during the COVID-19 pandemic. And I will say the state is now in the process of renewing its 1115 waiver. And one of the really important things that the state has raised up in that renewal is the idea of addressing nutrition at the household level. That's one of the issues that we've seen with sort of the medicalization of this approach, right? That oftentimes payers must target sort of the individual enrollees. And we know that nutrition is not sort of consumed just at the individual level. I know that any of these programs, produce prescriptions, medically tailored meals, medically tailored groceries, all know that when you give food to one person in a household, that food is going to be shared. And so if we're trying to have an impact on an individual with a chronic illness, that impact is going to be reduced because of that sharing. And also we should be considering the broader household, right? I think there's an incredible opportunity from a preventive standpoint if we're thinking about the household. And so I think that's an incredible step forward in that waiver if it's approved by CMS, the idea of being able to provide some of those supports at the household level. I'll also raise up some of the managed care opportunities that I think are really interesting and making some difference on the ground. One of those opportunities is the In Lieu of Services Authority, essentially an authority that allows states and managed care organizations to provide certain services in lieu of state plan covered services, provided that they are medically appropriate and cost effective as a substitute. This is a policy pathway that's historically over the last couple of years really often been targeted at behavioral health services, which is fantastic. But now we're seeing some interesting expansions of it into the social determinant space. And I would say the biggest example of expansion we're seeing right now is in California, which I know Emma can certainly speak to as she's well acquainted with those efforts. And really what they've just received approval for and are moving forward with is to allow the MCOs in California to provide a range of nutrition services as in lieu of services. So I think that's a really interesting pathway as well. And then lastly, I'll just mention the ways that some states are also thinking about value-based purchasing requirements in their contracts as another policy lever to encourage partnership and focus on social determinants of health. And the two states I would raise up there are New York and Pennsylvania as doing a good job of actually building in some teeth into those requirements and saying, yes, you must not only give attention to these issues, but you should be thinking about how to incorporate community-based organizations that are doing this work on the ground into those efforts. And so I think there are a number of, as I said, pathways that are opening that are creating some initial momentum and opportunity in the Medicaid system. And similarly in Medicare, very similar, we're seeing opportunities in the Medicare Advantage program, where in the last couple of years, Medicare Advantage plans have had new opportunities under these special supplemental benefits for the chronically ill to provide a much wider range of supplemental benefits to chronically ill enrollees, including nutrition benefits. So all of that is, I think, an incredible step forward in creating a lot of opportunity, but I do want to return back to that primary point, which is this is a patchwork approach. It's not necessarily equitable, while it is sort of a positive thing to be creating new opportunities. And so ultimately, I think while we want to lift up these opportunities and try and expand them across the country, we can't lose sight of that front door. And so I think when I think federally, I think if we're really talking about equitable access, at least within the healthcare system, and that's a whole other issue. I know we're talking about how, there is inequitable access to healthcare in this country. I think that's a whole broader issue to be tackled, right? I think healthcare is a right, it should be a right, and we should be tackling that as well. But if we want to think about spreading food as medicine across that system, we need to make change at the federal level to start thinking about how these can be built into baseline benefits. And some of the things that are exciting me there are some opportunities that we're seeing through federal legislation, and I'll let Alyssa talk about that in just a moment. But I also think there's opportunities to sort of raise this conversation and bring more people to the table around these recommendations. Particularly, we've seen a real movement around having a White House conference on food, nutrition, hunger, and health. The last one of these conferences was held about 50 years ago. It had thousands of recommendations come out of it, many of which were implemented and really guided food policy in this country for sort of decades afterwards. And so if we were to sort of revisit that idea and have a national conversation that really spotlighted food as medicine and some of these issues, I think we could see some real advancements. And I'm going to toss things over to Alyssa, but the last thing I'll make a plug for as an exciting policy is also thinking about how we can extend some of the policies that occurred in the wake of the pandemic, things like the increase to the WIC cash value benefit for fruits and vegetables. I think we can't lose sight of the fact that WIC fundamentally can be a food as medicine program, and it already exists and the infrastructure is there, and it is targeting an incredibly important population. And so during the pandemic, the amount of funds that could be used for fruits and vegetables in that program was increased. And I think it's a really important policy to be following and extending to make sure that that program continues to provide adequate access to fruits and vegetables. But then I'll stop and let Alyssa talk about one of the other exciting policy opportunities, I think, at the federal level, which is national legislation that would create a large pilot around medically tailored meals in particular.
Thank you so much, Katie. Oh my gosh, there's so much to discuss there. As a person who's intimately familiar with all the acronyms that have been used to deliver food to people and connect those systems, I mean, this could be a whole other webinar. I think the only point I'll make there before I briefly describe HR 5370 is even in these pilot programs, which are highly dependent on the state you live in, whether the insurance plan decides to offer it, et cetera, we also need to ask the equity question of whether that intervention is being used to the greatest advantage in those interventions. Is it actually reaching the people who need the services? So I think that's a question for later. But HR 5370, which I've just posted in the chat, is a really groundbreaking bill that was introduced by the Food as Medicine Working Group of the House Hunger Caucus. Mr. McGovern from Massachusetts, Jackie Walorski, Shelley Pingree, and Dwight Evans last fall. And the real focus is expanding the evidence-based and increasing the geographical representation of the evidence that we're getting to create a more efficient and equitable healthcare system. So I've mentioned some of the research, some of it's provided in your materials for this webinar, but looking at testing the medically tailored meal model in different states and geographies and gathering that evidence so that we can decide, does it make sense to incorporate? I think it does. I think the evidence shows it, but this is something that will really expand our knowledge. So it is a pilot run through Part A of Medicare, which is the hospital side of Medicare. It is designed to be run in at least 10 states, which is so exciting, in at least 20 hospitals where the hospital is partnering with an established medically tailored meal provider. So that's really looking at the quality piece of it. You're not going to get the research outcomes unless the intervention is a quality intervention. And I'll post the Food as Medicine Coalition's quality and meal standards guidelines in the chat if you're interested in those. But it's looking at a real lengthy intervention in particular populations that are living with certain illnesses. And then, you know, it will be evaluated as a whole to give us some of that outcomes data, hence the hospital side, and also the cost data that could help point us in the right direction, hopefully. So thanks, Katie.
Thank you so much, both Katie and Alyssa. So yes, the family and the conversation around also how do we reach the next generation? How do we really start early? I really appreciate the shout out to WIC. The idea that we don't need to create more systems to, but actually build on current systems. So I'd like to actually ask the next question to Emma Steinberg, as a physician and chef who worked on advocating for food as medicine in the Bay Area, and your familiarity with California legislation, et cetera. Could you comment on how to move policy forward? You're someone not in nonprofit, foundation, or government capacity, and also maybe could you can you talk specifically about your expertise and experience working with children, how food as medicine programs are key to improving health and outcomes for this particular group?
Yeah, absolutely. Thanks so much, Margaret. And thanks to everyone else on the panel so far for all that you have contributed. It's really exciting. I can't help but smile through all of this because it's just really, really exciting. And I think this question and issue that you bring up and that Katie was talking about, and I love the house analogy, I think it's really important. And I think we as citizens and sort of members of various different groups, whether we're citizens or not, is really, really important because there is a ton of power in local government, in administrative advocacy, and also from the physician side, or even just healthcare provider side, in organized medicine. And similar to what Dr. McMacken was saying earlier about minimal nutrition education and training, we as healthcare providers, and again, I can only speak to my training as a physician, sadly also are rarely taught about sort of policy, administrative advocacy, and other avenues to help facilitate change and really use our power and privilege as physicians to advocate for these really important and necessary changes. I also want to second a point and sort of theme that I think has come up a little bit, but also just say explicitly that all of these issues really have to do with racism and equity. So access to healthcare, access to food, all of that is sort of founded in inequities in our country and in racism. And all of those things are health issues. And so it's really important for us as healthcare providers to help change the healthcare system from within and really inspire each other to get more involved in policy systems and environmental change, because we aren't going to be able to change access issues to healthcare, and we're not going to be able to improve the health of our patients and communities until we truly address the root cause, of racism and equity. And we obviously can't do that alone. And as Katie mentioned, you know, there's a number of different systems, including healthcare, government, community-based organizations, and they're super complex in and of themselves, but also how they interact with each other. And so as somebody who is trying to get involved with something, it can be super overwhelming and really hard to understand. And I think from my experience personally, what I have found, fortunately, is that there's actually a ton of resources and a ton of opportunities for partnership. I think one of the other themes that seems to come out that many of the panelists have talked about is the importance of partnership. And this can be with local organizations. It can also be within your own clinic or hospital system, whether it's a government relations team or otherwise, connections to your local health department, or even, as I mentioned before, thinking about your local chapter of your organized medicine organization. And I think these groups not only can help you with specific issues, but they also can just sort of help explain, sort of like Katie's infographic, what are the timelines, right? When is budgeting important? When do bills get passed, right? There are sort of simple mechanics that are really important. And so I could go and try and have a conversation, but if it's in October and I'm trying to talk about something that passed back in June, maybe that's not the best opportunity and not the best sort of use of my time or my partner's time. So that can be helpful for timelines, but also identifying levers for change, right? So Katie mentioned that I've been involved with the in lieu of services advocacy that's been going on within California. If you had asked me 3 years ago what in lieu of services was, I would tell you I had no idea what you were talking about. You know, as a pediatrician, I'm not as oriented towards Medicare. I have a lot of interaction with Medicaid, but Medicare tends to be more oriented towards adult population. And that's not to say that all of these things are irrelevant. You know, just like Margaret and others were saying, we're really trying to shift this focus to think more about how do we reach the whole family. And so any patient can be an entry point, whether it's a pediatric patient or an adult patient. And fortunately, kids come to the doctor a lot, and pediatricians historically have a really strong focus and pay a lot of attention to prevention and nutrition. And so I'm biased, obviously, but I think as a pediatrician, we play a really important role and see a lot of different family members and are already having conversations about prevention and nutrition and other aspects related to public health, whether it's environmental health, smoking cessation, housing stability, all of these other structural determinants of health. It's normally in our conversations that we have with patients. And so whether we acknowledge it or not, we have a huge expertise and a ton of experience working with these patients, and we have so much to offer outside of just our sort of patient interactions. So that is all to say that I think after you use these amazing resources for partnership, for sort of learning and hopefully recognizing and sort of solidifying that you have a lot to offer as a healthcare provider in terms of your experience, but also your contact with patients and their stories if they're willing to let you share them. But I also think that one of the things that was so scary to me as a provider is, oh, I can't talk to my representative. They're busy. They have other things going on. But there are representatives, right? So talk to your local and your state representatives, share information with them, provide your contact information as a provider. You can help serve as an expert for them, maybe on a lead poisoning case or, you know, something else that's sort of related, but you can give them your expertise, give them a one-pager, tell them a story about your patient so that they know that you are a resource for them and you care about these issues and that it should be on their radar. And I think to Diana's point earlier, all of these issues, like I was saying with racism and equity, it impacts multiple sectors, right? The benefits of food as medicine has economic impact, it has agricultural impact, it has health impact, it has social services impact. That's basically all of the sort of panels and policies that exist within like our governmental system. And so if this isn't something that they're realizing or sort of putting those connections to, you as a healthcare provider or your team and partnership can sort of highlight for them and say, this is really clear and obvious. We really need to be thinking about these things. And, you know, you sitting on, you know, or having conversations about economics and agricultural policy, well, that impacts this too. So it all should be sort of having the same it should be all in the same conversation. And then I'll just make one more point and then I'll pass it back to the rest of my colleagues, is that I think finally there's a huge opportunity for us to share our voice otherwise by leveraging the media and thinking about opportunities to write op-eds. I think in this particular case, a lot of people have been sort of talking about, well, is it a social service? Is it a healthcare issue? And we as providers and people who are on the ground have an opportunity to help shape and change that narrative. You know, and I think it can be hard for people to sort of wrap their heads around, well, why should healthcare pay for this? Or, you know, why is this important to sort of thinking about it from a health perspective? But I think op-eds and sharing our stories and sharing our perspectives and leveraging the media is going to be critical to change this narrative and highlight the importance, the true connection to health, the importance of food as medicine programming within healthcare, and the need for us to be really thoughtful about sustainable funding and integration of these programming sort of in multiple ways across multiple sectors in order to have the best and most equitable access. So thank you.
Thank you, Emma, for bringing complicating the narrative further. Really appreciate it. And it is it does consist of so many intersecting systems that are in and by themselves very complicated. But I really like your language around leverage, and that comes from all of you, equity and power that we actually have, and also the power to influence our elected officials. I appreciate that shout out. So now we actually, we've heard from all our panelists individually, and so we have a question to the panel from Diana Johnson, actually suggested that we should address this question as a group. The recent Aspen Food as Medicine research report suggested equity, and you've addressed equity, so we're going to dive in a little more to this conversation. That equity should be embedded throughout the food as medicine research continuum. And equity is also a very important focus of the Urban Food Policy Institute, so this is really in our wheelhouse and our shop. So the question goes on to say, how do practitioners, researchers, and funders, how do organizations strive to understand the diverse experiences and broader context of the population that will receive or has already received a food as medicine? So I'd like to expand on some of the topics that you've already brought up. And any of you can jump in.
I'm fine going first, folks. Since we started with me, I guess. Thank you so much for that question, Diana. I mean, I think equity is front and center, and I was an advisor, I'm privileged to be an advisor on the Aspen project, and the most transformational piece of that brief is the central role of equity when we approach food as medicine interventions, especially as we approach the people who need them. You know, it's about respecting and understanding the embeddedness with which people come to food. You know, food is multi-vectored. It's not just the nutrients we put in our body. It's community, it's health, it's culture, and it's fraught. You know, thank you, Emma, for bringing that up. You know, it's the whole of history, and food is intertwined with racism, colonialism, and more. And it's something we come to 3 times or more a day, more for me. And it's not like systems we interact with less frequently. It carries a valence depending on who you are in the space. And I think the difficulty with research is that we can't research food the same way that we research medicine. It's not able to be reduced to a pill because of what I just mentioned. So we have to diversify the way we look at it from a research and a service perspective. And so, you know, from the agency perspective, to me, equity is at its root about valuing humans, and God's love has served the most vulnerable in our communities for over 35 years. We welcome all, no matter what, and we work to make our services free and full of dignity. We largely serve communities of color and those experiencing health disparities at alarming rates, and that is a huge equity stance. But that being said, if the events of the last years have shown us anything, it's that we all have to reconsider our stance and ask how we can do more in the face of enduring structures of racism. And that deeply includes service agencies, because I think it can be easy to point to your clients or your mission without a moment of self-reflection. And I know that we can do better. We can always do better, listen more, and strive to understand and honor the people we serve. So to the practicalities, you know, God's love does have many ways of hearing about the lives and the context of our clients, through the in-depth intake process, where our RDNs go through an interview with each person, to meal tailoring, and then standard client surveys, and we have a client advisory board, just to name a few. But as a person who's interested in research and equity-based research, I think those avenues are really only as good as their methods and the spaces that we create to listen and absorb and respond to our communities. And so we strive to make them better and ask how we can, you know, who we're not hearing from, and what we don't know. And so there's a few places we're concentrating on right now at God's Love, and there's always more. But we recently redesigned our client survey, the one that I mentioned, to be more accessible in different reading level, to be shorter, available in multiple languages and on multiple platforms. And we were able to see a greater diversity in the respondents and a much better response rate. So that was cool. And then one of the other areas is based on our internal DEIA initiative. We are looking at our outreach, and by overlaying heat map data and other knowledge about who needs our services, just asking the really difficult service question of whether we're reaching our mission critical population. And I think I'll just finish with like one of the hardest populations to understand for service providers, and yet I think the most critical, are those that decide not to access your service, even though they might be eligible, and, you know, asking the questions about why didn't they? Was it access? Was it something else? And, you know, assessing and understanding that population for me is one of the harder things. And I hope we can increasingly focus there to make sure that we truly have a no wrong door entry system. So I will pause and let my fellow panelists continue.
Thank you, Alyssa. In the interest of time, I'd like to add just another aspect, which has not really, interestingly enough, made it into our conversations as much as we might have thought. But how has the pandemic affected the need for and access to, or exacerbated these inequities or these inadequacies of our current system?
I can jump in quickly. I just, yeah, I think it's really interesting how the dialogue around the need for food as medicine and addressing chronic disease prevention and treatment as risk factors for COVID. I think that it's very interesting how that dialogue has kind of exploded in light of the pandemic, and I appreciate it, but I think it's also ironic because these same comorbidities have been around regardless of whether we had a pandemic or not. You know, we know heart disease is still the leading cause of death in the United States and so forth. So I welcome the fact that there's more dialogue around it, but I also don't think it always needs to be tied to our risk factors for COVID severity. I think we, in and of itself, everyone deserves to have an opportunity to work with nutrition and have access to healthy food to be able to be healthy, independent of the pandemic. You know, and similarly, I think, and I will admit I'm just as guilty as probably the next physician or provider, but I think that one of the things that's come out of the pandemic is this just this unbelievable awareness around food insecurity. And, you know, working with the population that I serve, I already had a pretty strong awareness to begin with, but it was, I'm sure everyone can attest who sees patients or works with these communities, it was just, it was crippling to see what was going on with my patients through these televisits and, you know, phone calls that we were having throughout the early parts of the pandemic. And so many people did not have access to food. And obviously that is continuing to linger. And just like with comorbidities, this was a problem before. And I think it's wonderful that we're having this new dialogue around it. And I'm glad that health systems and especially ours have really started incorporating not just the screening for food insecurity as a routine part of care, but also developing new resources to address it. And, you know, of course, all of this ties into the things that Alyssa and Katie and others have mentioned around the bigger picture and how we need more we need to really look at how can we get all of these incentives and benefits through the front door. And I just love that analogy. I'll stop there, but I think those are two things that strike me about the pandemic.
I'll just jump in really quickly. Oh, I know a bunch of people just unmuted. I just want to second the increased awareness, I think is huge of food insecurity, but I also would say of health inequities in general. I think in pediatrics, we've always been very focused on thinking about ACEs, so adverse childhood experiences, and other social and structural determinants of health. But I feel like the conversation has expanded to many other sectors. You know, the question is then, will people put their money where their mouth is? And will we actually be able to make tangible change to shift in other sectors to sort of move towards prevention and opportunities to keep patients out of the ER and out of the hospital? And then the other piece that I'll just say is just echoing back to what Katie said also, is we've seen the massive benefit, at least sort of in the pediatric population, of the expanded benefits of things like WIC. In California, they've now expanded, so they have universal school meals now that's going to last outside of just the pandemic waivers. And so thinking about sort of opportunities both within the healthcare system, but also other benefits, like Katie had mentioned earlier, I think is really, really important, and advocating for those things that we've seen huge benefit from already.
Yeah, and I just want to follow up on that point, because I think that's a really critical point to be thinking about in this moment, because, you know, what was the impact of COVID in these services and policies? Well, I think across the board, what we've heard from all of the organizations that we work with in this space is that there was obviously an incredible uptick in need, sometimes in the range of 30% increase in the demand up to something like 70% increase in demand. So, and we saw that, you know, in response to the surges and the start of the pandemic, and with that came a lot of policy change and support and funds, you know, not necessarily enough to tackle all of it, but important supports that were put in place, including things like the increase in the WIC CVB, also expansions across states and things like home and community-based services and Medicaid that have historically provided an opportunity to connect patients to meals, and just simply making it a little bit easier for people to access these things on the ground. So some of the flexibilities that were put in place around WIC and through uses of things like telehealth and a relaxation of some of the requirements there, I think are all very positive. But I think what Emma's bringing out is we are now in a moment where we may be facing some policy cliffs. And so we need to be thinking about that. What does it mean in the next year, 2 years, if, you know, fingers crossed, things are hopefully getting better in the COVID-19 pandemic. I don't know that demand is necessarily going away. And so I think we do need to be thinking about which policy changes have been most beneficial and which need to be maintained, and how we do that so that we don't have people who are sort of falling off of these services who have been connected to them over the last 2 years. So I just wanted to note that I think it's incredibly important as we think about this right now.
And if I could jump in there, I'd like to just, echo everyone that, of course, COVID was a major disruptor. We heard that across the field and with our grantees as well. And then, there's been some research about food insecurity during COVID. And when you dig deeper and see the data stratified by race and ethnicity, you again see that drastic disparity. And I think it's important not just, to understand those disparities, but also how that informs our program design and evaluation of the programs we're hoping to roll out, and to really think about the importance of the lived experience and how that can really shine a light on why folks are not engaging in these programs. Our foundation is funding a research cohort to look at both quantitatively but qualitatively do some focus groups. I'm thinking of Duke University in particular that's doing some work to look at, some of those barriers that don't really come out through just regular surveys, but things like transportation issues with access to food, community trust, language barriers, immigration status, the list goes on, to really understand, from these groups why there could be gaps in accessing what could be a really excellent program, but, feels unrelatable to them or just doesn't make sense. And it's just one last point, that I remind myself often that we're talking about food as medicine today, but food as medicine is not a new concept, and it's certainly not a new concept across cultural groups. And I think that there's something to that, and thinking about the communities we're serving and really being good listeners and hearing from communities about the history of food as medicine across those cultural groups.
I want to thank you all for everything. And but Diana, particularly that last piece speaks very strongly to a lot of the work that we are doing and that I'm deeply involved in is the listening and the appreciating that heritage of food is medicine that is thousands and millions of years old, but has been carried forward. And much of it is unseen, invisible, and unacknowledged in medicine and in nutrition education. And so I hope we can flip that narrative as well. So we are actually, we've moved a little bit into the time that we wanted our participants to pose questions. So I'm going to check with Rosita where we are in the in questions, curating good questions for you.
Hi, Margaret. Thank you very much. We had quite a good amount of questions touching on different dimensions of food is medicine. I'll share a few of the one that summarize, given the time constraints we had, the summarize points across our audience, and hopefully we can get to as many as possible. And now we'll start actually with a question from Nick Freudenberg. Dr. Freudenberg is Senior Faculty Fellow at the CUNY Urban Food Policy Institute. And this is a question for the entire panel. So many of you have described the potential of some of the risks of the concept of food as medicine. I wonder if some of you could highlight what you think are the greatest risks of misuse of food as medicine, co-optation of more meaningful food or healthcare reform, entry of commercial actors who look for profit from the idea, etc. Thank you. And any of you can address the question.
Well, at the risk of always being the first one to jump in, thank you so much for that question. And it's a big one, so I don't intend to answer it completely. I'll let my other colleagues jump in. I think when we're addressing food as medicine, I come at it obviously from the community-based provider perspective. And the first question that I always ask is, who is it reaching? And what are we providing? And has the community had input on the provision of that service and what it looks like? And so, you know, when food as medicine, as we've all said, is not a new concept, but it has definitely experienced a resurgence, whether it's COVID or the current climate or the current administration or whatever it is. And I think there are many different definitions of food as medicine. And I always want to start with what are we talking about when we're talking about food as medicine? And that's why I think the Aspen report is so groundbreaking, because it spends a fair amount of time getting to the actual discussion of research by framing what we're talking about. Who is getting it? What are they getting? What is food as medicine? What are the interventions? And, you know, we can't really have a meaningful conversation about food as medicine until we get to that point. And so, I think that as a mission-centered organization, our commitment is always providing the best quality and the most nutritious intervention to our clients in a way that is acceptable and accessible to them. And so, of course, when you scale that, you know, concerns can come in about, you know, the quality, the accessibility of the community. And that's where my concerns would come in. I think it was you, Diana, that said, you know, communities know their people the best, right? And many community-based nonprofits tend to be connected to their communities. So I'll pause there and let my colleagues jump in.
So I thank you so much, Alyssa. I'd like to push that a little harder. So one of the panels that we've, the House Hunger Caucus and Friedman School of Nutrition Science had a panel discussion on food as medicine. And two of the panelists were someone working in supplements, right? So the supplement industry. So this idea that food as medicine is now going to be in a pill as antioxidants or whatever the product is, but it expands that field. And the other panelist that was an interesting addition was a person from the life insurance industry, where food as medicine is not also an incentivized activity. So I'd like to push the narrative a little harder into the who is going to truly profit from this concept if we cannot, Alyssa, control the narrative.
I can jump in there. My mouse froze for a second, sorry. You know, what you're mentioning is, you know, kind of what I was alluding to earlier with the commercialization of these programs, and that there is a huge stake in this for the private sector. And so that is kind of going to be the push and pull between, you know, the not-for-profit sector who's originally created and delivered these programs, and the private sector looking at the development of these programs and thinking about the potential profit and expanding them as well within their own systems. So it's to say that it exists, you know, and it is going to be a huge part of the narrative moving forward, even as we scale these programs and think about how they're going to even impact the policy advocacy that's going to go into this, both at the federal and state level.
The other thing that I want to bring up here too is how do we need to think about the supports and resources that need to be in place to allow some of those community-based organizations that have sort of really dedicated themselves to this mission and are delivering a really high quality product to continue to operate in this space. So the point I don't think that's been brought up yet, we've talked so much about policy and creating coverage, and that will pay for services. But there's also huge infrastructural needs here that I just want to raise, because we need to be thinking about that from sort of from a policy perspective as well. You know, one of the hurdles that we've seen that even as policies come online that allow payment from the medical system to these services is the infrastructure that's needed to create really robust, well-organized community clinical partnerships, right? So a lot of community-based organizations don't necessarily have the technology or knowledge in place to navigate things like HIPAA, for example, the exchange of patient data and effective referral systems, and really to think about sort of the upfront costs associated with putting that infrastructure in place. And I think that's an incredible key when we think about this issue of who benefits, who profits, who is at the table here. I think as we talk about sort of the private sector, right, one of the benefits that they often have is that a lot more capital to deal with some of those upfront costs and experience in that space. And so I think there is something to be said for leveling the playing field a bit and making sure that we're providing resources to that end. So for example, in Massachusetts, in line with our 1115 waiver, the state also created what was called the Social Services Organization Prep Fund. With this, it was a grant program specifically targeted at providing funds to organizations on the ground that needed to address some of those upfront costs in order to create a partnership with our accountable care organizations. And I can say that that was incredibly helpful to making that program real and to allowing even smaller organizations to participate in it. And I think it's something that's going to be really important to continue in our state, but also to think about nationally. So how do we get at those upfront costs?
Thank you so much, Katie. And yes, lots of infrastructure challenges, both at digital, but also physical infrastructure. So we have so many questions. So I'd like to shift a little bit, and we have a question for Katie from Lynn Fredericks. Are you seeing shared medical appointments as well as an approach? Curious if it's not explicitly part of the House infographic, but maybe it's embedded within the things that you are listing. So if you can speak a little bit to that.
So in shared medical appointments, I'm going to frame it one way, and then if I'm getting it wrong, somebody correct me. So I think there are definitely ways that we are seeing things like the embedding of these services into actual healthcare facilities and tying these to existing medical visits. So for example, we know that some prescription programs are looking for opportunities to integrate with things like diabetes self-management education, diabetes prevention programs. And I think that's a really great way to sort of take advantage of systems that are already in place, especially for diet-related chronic illness, and make that connection. We've also seen similar approaches with things like well child visits. And so I think there are a lot of opportunities created there. On the flip side, we've also seen things at, say, food providers, so things like food banks that are thinking about how they can sort of integrate some key screening and nutrition education and services to their facilities. And I think that's a really great approach as well, because I think one of the challenges that you could see on the ground for participants is the more visits or the more travel that is required, it can be a real barrier to access. And so thinking about how you can be as sort of efficient as possible to sort of build some of these things into existing medical visits or existing visits to other resources can be really powerful. But if I'm getting at the wrong question there, let me know.
No, I think that you got it. I do want to address something that a question also, and we don't have a lot of time, but I think we have to acknowledge the appearance that this is a very white and female panel, right? So one of the questions that we got was, how do we diversify representation in these conversations at the table in multiple ways, both in terms of professions and political focus, but also in a representation of our population. And maybe there isn't a response other than we have to acknowledge that we may appear I'm not sure that is the truth, but we may appear as a very cisgendered female white panel. And I don't know all of our histories, but I think it's very important. And I think you've all alluded to, Alyssa, your board of actual participants that feeds back information. All of my research is informed and co-led by the communities that I work with. And my understanding is the same as representative for the rest of the panelists. So I want to go to a participant question. We have so many that I'm not sure where to begin or where to end, but so that was one that I wanted to acknowledge, and so I'm scrolling. So I have there was a question around actually more sort of a practical. What are your thoughts around, so one of the new initiatives are sort of specifics are Vegan Fridays in New York City schools, so serving plant-based meals to children. And that's Emma Steinberg, that question is for you.
I think any opportunity to expose kids and interact them to more taste, textures, flavors, everything is great. As a chef and someone who teaches cooking classes, I always want to see how much we can get the kids involved, especially also with their own families too, because I think passing along traditions through food is going to be really important. And in my experience in working with kids, they're more likely to try new things the more they sort of interact with food and sort of see how it's made and grown and all of those things. I think it extends also into thinking about farming and food sourcing as well. So I would say, Meatless Monday is something that came out a long time ago. So Plant-Based Fridays, which I know is sort of pushing as another thing, all of it is great. And I think any sort of way for us to sort of shift conversations and try to just create a healthier relationship to food is going to be really, really important. I think for me as a pediatrician, it's really just about what is that relationship with food and how can we make sure that we really are tying it back to people's cultural backgrounds too, and making sure to celebrate that as something that's really important. And so as long as it's not being viewed as something that's like super restrictive, or there's any sort of positive or negative connotations that are being tied to food, but as long as it sort of stays as a sort of celebratory and exciting thing and sort of a different way to interact and think about or tell stories or pass traditions along, I'm all for all of those things, again, just as a mechanism for just trying to create a healthier relationship with food. And I don't know if people want to sort of talk more specifically about that. I don't know if Michelle or others have thoughts.
So unfortunately, we have so many things we could continue to talk about, and we have many more questions. I want to acknowledge the questions that have to do with food quality in our emergency food system, or even the various systems that we propose to support people who are food insecure, that are completely tone deaf and that are more about delivering calories in paper bags rather than understanding communities and actually delivering quality food. I wish we could continue this conversation on social media, and maybe we have an opportunity to do so, but I want to thank everyone who attended. I want to thank our panelists for this lively conversation and these really passionate statements and all of the work that is going on the ground. We encourage you to continue the conversation on social media, and you can use the handle Food is Medicine, and you can tag our panelists individually or the group, and certainly tag the CUNY Urban Food Policy Institute and myself. And then I think Rosita is going to maybe just remind you of the next events from the Food Policies Institute. And again, I thank you for the opportunity to have this conversation. We should continue